increasingly, as there's more public media coverage, television, newspaper, radio, social media, of what palliative care is, that it's for anybody with a serious illness, patients and families are coming in and demanding it from their healthcare system. And very often they will encounter a physician in my age group, or maybe 10 or 20 years younger, who trained during an era when there was no such thing as palliative care. And many doctors and even nurses carry the incorrect belief that palliative care is the same as hospice. And that puts patients and families in a very tough position of essentially having to educate their doctors. So what I suggest that people do is bring printouts from the internet, for example, from a consumer website called getpalliativecare, all one word, .org, which explains what palliative care is, that it is not about only those who are dying, it's about anybody with quality of life challenges and a serious illness. And say to your doctor, look, you know, I appreciate that that may be your perspective, but that's old-fashioned. The modern concept of palliative care has nothing to do with prognosis. And, you know, I read that people who get palliative care not only feel a lot better and manage to stay away from ERs and hospitals, and you know I don't want to be in the hospital if I can avoid it, they also live longer. So I can't see why you wouldn't want me to have that kind of care. You have to insist. And if your doctor won't help you, then go get it yourself. Unfortunately, in our healthcare system, it's let the buyer beware. You have to advocate for yourself. You have to advocate for your loved one, just at a time when you don't feel like advocating because you feel crappy and you're exhausted and you're stressed and you're overwhelmed. That is the very time when you have to advocate most strongly for yourself, because we have a very chaotic, fragmented, some would argue really broken healthcare system. And to get what you need from it, you have to be a very informed and assertive consumer. And having taken care of my own family members in this system and experienced even as a physician with expertise in this area, how hard it is to get the system to respond to what you, the family who really does know best what your loved one needs. I know how hard it is. It was very hard for me, and I'm a doctor and have been around the block and I'm well known. And it was still very hard for me to get people to listen to what my parents needed, to what my son needed. And the important thing is not to let that, not to take that personally, not to be intimidated by it, but to remember that in fact you do know best. Nobody but you, the person who's caring for this person day in and day out, if the patient can't speak for themselves, and to trust yourself. And to not let the resistance to listening to you make you think you might be wrong. I know this is very difficult to do, but the people who do that get better care for their loved ones than the people who cave. So when that oncologist says to you, oh, you don't need palliative care, you're not dying, you can say to him, you know, you have an incorrect conception of what palliative care is, and here's some articles about it that I printed out, and here's this website that you might want to take a look at. But my reading says that people who get palliative care at the same time as cancer treatment live longer. They live better and they live longer. So I'm not sure why you're not helping me get access to that kind of care. And if you won't, I will go find it myself. And the reason I'm saying to the public that they should do that is because eventually that will change physician behavior. Because as rigid as doctors are, and as certain that we know everything as we are, we do respond to market forces. And if patients and families are saying, look, I want the best care possible for my loved one, and part of the best care possible is palliative care at the same time as disease treatment, that will, after a while, cause people to shift in their understanding and in their recognition that their patients need more than the latest chemotherapy cocktail. So I guess what I'm saying is we need help from the public to drive this access to this kind of care. Because it is very hard to lead a conversation with your doctor, because it is not an equal power relationship. because patients and families are hyper aware of how little time the doctor has. They've already been waiting 2 hours to get in. They know there's 50 people in the waiting room to get in. It's really hard to take control of the conversation. So I think one thing that is very helpful to do is say, we have questions about the pros and cons of the different treatment options. And I realize that you may not have scheduled enough time during this appointment for us to discuss that with you. So we'd be happy to make another appointment so that we have time, enough time, to really understand what benefits and burdens we should expect from the various treatment options that are in front of us now. Or we can try to talk about it now. But what that does is respect the fact that the clinician is 4 patients behind and under stress. Probably not the best time to have the conversation. And enables them, A, to be prepared, because you're giving them a heads up that you want to talk about this, and do their homework, because they may not be realizing that you actually want to step back and weigh your options. So it prepares both parties. And it won't be a visit for blood work and vital signs and weight and checking your counts. It'll be a visit to talk. And it should be a longer visit, not a 10-minute visit, a 30-minute visit. And then I would walk into that meeting and ideally send them ahead of time by email with questions. Basically, the way I frame this to families and talking to doctors is to ask for the best case scenario, the worst case scenario, and the most likely scenario. So if you were talking to me and I'm the oncologist, the best case scenario is that this 4th line chemotherapy will get a handle on your cancer and shrink it for as long as possible. The worst case scenario is that it won't work at all, and that it will add additional cost and symptom burden to you. It'll make you tired, it'll make you nauseous, it'll keep you with low counts so you can't go out because of infection risk. And then I'll tell you which of those I think is most likely. That really helps you, right? Because I'm going to say I think the worst case scenario is the most likely. I don't have 100% certainty, but I think it's the most likely. What I'm doing then is sharing my professional judgment with you. I'm not saying, well, we could do nothing, or we could do, 4th line chemotherapy. Because what are you going to say? Well, give me the 4th line chemotherapy. I'm not informing that decision with anything about what I think you're going to get from that 4th line chemotherapy. And then you can make a more informed decision. So what would happen if I didn't take that chemotherapy? Number 1 has to be that I will still be your doctor. And you and I will work together to give you the best possible quality of life for as long as possible. There are lots of other things we can do that don't include chemotherapy.